Good afternoon. I'm Jana Martin, Chief Executive Officer of the American Insurance Trust, known to most of you simply as the Trust. We are delighted that you're able to join us virtually today for the next webinar in our virtual webinar series. The Trust is pleased to be able to offer this informative content free of charge to our policyholders. As a Trust policyholder, most of you are likely familiar with our risk management consultation service, the Advocate 800 program. It's one of our many benefits that our insureds receive through the Trust. 3 of our advocates are with us today, Doctors Mark Martinez, Julie Jacobs, and Lisa Bryant. This credit can be combined with 5 other CE credits from any of our other live or on-demand virtual webinar series to save 15% on your Trust-sponsored professional liability insurance policy. I hope you benefit immensely and actually enjoy this roundtable. Please join me in welcoming Doctors Bryant, Jacobs, and Martinez. It's up to you.
Great. Thanks so much, Jana, and welcome to all of you. We're glad to be here with you today. We have a couple of different topics we're going to start with. As usual, we'll start with our initial questions that we get from folks who've already been asking these kind of questions ahead of time, and then we will dive right into the live questions. So feel free at any point to go ahead and enter your live questions, and we will get to them very quickly. So, all right, Julie, I'm going to start with you first. And this is a question we're getting more of because it's about Medicare changes coming up. So as you know, during the public health emergency, Medicare waived some of their requirements, right? In particular for the periodic in-person visit with Medicare patients. However, as we know, recent guidance from CMS indicates that those the requirements for those in-person visits are going to go back into effect when the PHE or the public health emergency ends. So can you tell us a little bit about what those requirements will be and how that might change telehealth only practice?
Yeah, it's a great question and of a lot of concern to a lot of people. After the public health emergency ends, which as of today, it's scheduled to end on April 16th of this year. It may well be extended again. It gets extended for 90-day periods. Unless it's extended, as of April 16th, Medicare patients who are receiving telehealth services must have an in-person, face-to-face visit with their provider within 6 months prior to initiating telehealth services. For people who started telehealth services during the protected or the PHE, the health emergency, that in-person session will need to take place within 6 months of the end of the PHE. That requirement doesn't apply to people with diagnosed substance use disorders or a co-occurring mental health disorder. After that initial 6-month in-person meeting, there needs to be a subsequent in-person meeting within 12 months, and then every 12 months thereafter. There are some exceptions in the regulation for those 12-month meetings. There is not an exception for that initial 6-month meeting. The exceptions for the subsequent meetings, there's not a lot of detail about what that would entail, but it basically says it needs to be based on the beneficiary's circumstances and it needs to be documented in the record. The commentary gives a couple of examples of those exceptions. It talks about the fact that if the patient and provider agree that the benefits of an in-person meeting are outweighed by the risks and burdens of that meeting, and that decision is documented in the record, then that 12-month subsequent meeting can be waived. So then every 12 months, you would have to demonstrate and document that analysis. One example that they gave was that if the clinician has deemed that the patient is clinically stable and that the in-person meeting would create an undue hardship on the patient, then that would be an acceptable excuse to not have that in-person meeting. They also have an allowance that if there is another practitioner from your group practice with the same specialty as you, that person can provide the in-person meeting. That's probably not particularly helpful in our context, but it is another way around that in-person meeting. I mean, bottom line is if you have a teletherapy only practice and work with Medicare patients, or if you work with Medicare patients under SIPACT, this could have a significant impact on your ability to work with Medicare folks. Because there is no exception for that initial 6-month meeting, in-person meeting, you would need to have some way to have an in-person meeting with the people that you've started to see during the PHE or that you see after the PHE. If you're seeing folks remotely in your own state, that may be doable. You may be able to borrow a colleague's office or rent an office and do those periodic meetings and meet that requirement. But if you're working in SIPACT, or if you're licensed in several states and working into other states under those licenses, it's going to be really difficult. You're going to have to travel to your patient, or your patient's going to have to travel to you for that initial 6-month session. So the unfortunate reality is this may preclude people from being able to work remotely with Medicare patients in a lot of situations. We've had some information saying that SIPACT is aware of this issue, but they have no influence over insurance. And so they do plan to discuss it as an informational item at their next meeting, but they're not likely to take any action. There's not much they can do. And so SIPACT has indicated that if you want to try to affect some change here, maybe working with APA or other national organizations on advocacy efforts might be helpful. There's been a lot of advocacy already, and so I'm not sure how realistic it is that requirement is going to be waived, but maybe there will be a requirement or an ability to have an exception for that initial 6-month meeting. From a risk management standpoint, if you're suddenly thinking, oh my gosh, I have 10 Medicare clients, I'm not going to be able to meet them in person, you may need to terminate and refer them out. You need to engage in a proper termination process. You need to document what you've done to ensure that you're not abandoning your clients or ensuring continuity of care for folks. And so, although it may seem like, oh my gosh, I have to stop today, you do have a 6-month window within which to go ahead and start that termination and transfer process after the public health emergency ends. So we can't throw out the risk management strategies, we can't throw out clinical care, but this is really going to throw a wrench in the works for a lot of folks who are working remotely with Medicare patients.
Mm-hmm. Yeah, thanks, Julie. I think it is going to be really problematic for folks. And just to recap, right now you're speaking only about Medicare, right? And there's these two sort of periods. The first period is this initial 6 months. And so that's the one that really has to be in person. They are requiring another in-person visit during the remaining 12, like every 12 months thereafter, but that one does have the option for a hardship exception. So that may be more manageable, as you said. I just want to sort of underscore that. So it's really that the 6 months that could be really problematic.
Yeah, exactly.
Mark, anything you want to add there?
I think on the topic of termination, when you mentioned that, when we refer to ethical termination, there are a few things to keep in mind. And this comes up with some frequency over the calls, at least the ones that I've experienced. I'm sure all of us have. But you want to gauge the pre-termination counseling duration based upon how long the case you've been working on the case. So for instance, there's a big difference between somebody you may have seen for 1 or 2 sessions or somebody you've seen for a year. You want to be sensitive to that and allow sufficient time to engage in that pre-termination counseling. The other aspects that you want to keep in mind are the clinical recommendations that you have, making those clear to the client, as well as the risks associated with not following the recommendations as you see them, and then clarifying, of course, the referrals if they're indicated.
Yes, no, that's great. Thanks. And then I'll add to that, documenting everything very well. As we know, that's one of our key risk management strategies in all contexts. But yes, no, so that's great. Okay, Mark, so I'm going to send this next one to you. And this is actually a 2-part question. So I'll start with one part now, and then I'll come back in just a minute and add the second piece. As you know, one of the things we see that raises clinicians' anxiety quite significantly is when a patient presents with suicidal thoughts or intentions, right? And that's obviously makes them stressed, understandably. The first part of this question, I want to focus just on sort of general risk management strategies for that sort of assessment when that happens. I'll come back in a minute to the more concrete specifics on high-risk situations. But just for this first part, what would you say are some of the key risk management strategies that clinicians should sort of know in advance and employ in those situations when a client presents with suicidal thinking or behavior?
Yeah, so from a general perspective, the tried and true risk management strategies are going to continue to apply. So having a thorough informed consent process, especially as it relates to state mandates and the limits to confidentiality that might exist. Documentation, of course, in a manner that's going to be responsive to the level of complexity and the risk present in a particular case. And then also consultation with experienced colleagues. So more specific to the assessment of a client's suicide risk, I recommend incorporating a structured method for assessing suicide risk. And ideally, this method would be established before a client expresses suicidality. Julie, which I took from her, being forewarned is being forearmed. I really like that sentiment because I feel like that captures exactly what we're looking at. Ideally, we're going to be prepared because it's much more difficult when you're in the midst of a very highly stressful situation with a client who's expressing suicidality to manage it with a clear mind if we're not prepared ahead of time. So some of the benefits of incorporating structured methods for assessing suicide risk include comprehensiveness. You're less apt to miss assessing an important factor. There's a consistency across time, so you're looking at the same factors over time, which would then allow you the ability to track increases or decreases in risk across time. So when I refer to a structured approach, this may be based on consideration of factors that have been identified in the literature that places an individual at an increased risk for suicide, or perhaps it's through the use of research-based suicide risk assessment tool. A few examples are the Columbia Suicide Severity Risk Scale, the Ask Suicide Screening Questions, the Beck Hopelessness Scale, or the Suicide Status Form, which accompanies the Collaborative Assessment and Management of Suicidality, or CAMS approach, which is available in David A. Jobs' 2000 book, which is entitled Managing Suicidal Risk, a Collaborative Approach. I believe that citation will be made available to you in the comments or link. So ideally, what will happen is that this structured method for assessing risk will be used in conjunction with other clinical information and incorporated into treatment and documented in detail.
Great, thank you, Mark. And you are right, at some point here, you'll see the references. Anytime there's a reference, they'll be noted in the chat box. So you can look there if you want to find the exact references. Julie, anything you wanted to add there?
Just real quickly, piggybacking on my own comment about forewarned is forearmed. I think, there's a lot of practitioners out there who don't see what they consider high risk clients. They screen out for these kinds of folks, and they have a different type of client population, but you never know. And so even if you think, I don't need to know a lot about suicide risk or risk assessment, I don't do that kind of work, you do need to know it, because you never know when that might pop up. Someone might have a crisis, and a worried well client may end up being, having some suicidal thoughts. And so you do need to have these tools in your toolbox, even if it's not a primary focus of your practice.
Right. And yeah, we're going to come back to that exact point, because I think now we are, clinicians around the country are seeing people that they thought wouldn't, their population isn't sort of normally the population that might experience that. And in fact, they're having to address that themselves. So we'll come back to you on Mark on that second piece in just a minute. But I do love how you said, Mark, about the structured assessment, because then I think it allows really easily for the treatment plan to come directly out of that structured assessment, right? To be directly informed. And then, as you said, lends itself so well to that documentation, and you can clearly show, sort of what the issue was and how you are addressing it clinically in order to meet that need as maybe the risk level rises and falls throughout treatment. So yeah, that's great. Okay, Julie, so I'm back to you on a completely different topic. And the first, we have a little vignette, and then I'll ask you a question at the end of that. So a patient informs me, their clinician, that their prior psychologist engaged in some inappropriate boundary violations, asking them out on a date, making comments about his appearance, attractiveness, that kind of thing, making the client very uncomfortable. And in fact, so uncomfortable that the patient finally terminates treatment with that prior psychologist. As a clinician, right, most of us would then speak with the patient in this vignette. I speak with the patient about the fact that these actions are inappropriate and unethical, and of course, inform the patient that you can report to the board, here's kind of the ways that you can handle this. However, in this instance, the patient is adamant that he doesn't want to report it to the board, nor does he want me, the clinician, to report it. Really adamant, doesn't want any action to be taken at all. So what sort of would you recommend here? And in particular, the question, as you know, that we often get asked is, am I, as a licensed psychologist, required or mandated to notify the licensing board when I hear of something that, of course, this is clearly unethical behavior? Am I mandated to report that?
Yeah, it's a great question. And there's a few different things to consider. We have the ethics code and we have state laws and regulations, and those two are not always the same. And the state regulations and laws certainly vary widely among the 50 states. In a lot of states, psychologists are required to report violations of that state's Mental Health Practice Act, impaired professionals who may be impaired by mental health or substance use issues. And so a first step might be to look at your state's laws and regulations and see, does that kind of a mandate exist? An important thing to note is that many of those mandates actually have an exception if making a report would violate patient confidentiality. And so it's really important for you to get your eyes on the actual regulation or speak to someone who can look up the law or regulation for you. Just as an aside, something all of us should know how to do is find the laws and regs in our state. So you can go to your state licensing board. They'll usually have a button that you click that says laws, policies, regulations, something along those lines, and it'll link you directly to what goes on in your state. So step one might be to see, is there that kind of a mandate in your state, or to call one of us and see if we can help do some of that research for you. And if there is a mandate, does it contain an exception for confidentiality? It sounds like in this example, the patient wouldn't authorize the release of information, wouldn't want the clinician to disclose anything. And so there would be nothing more to do at that point. But if the patient eventually changed their mind, perhaps you work with them clinically and they come to a place where they would like some accountability, then you would get a release of information from them to make that report as required to the board. In addition to the state regulations, the ethics code also speaks to addressing ethical violations. Section 1.04 and section 1.05 talk about informal resolution of ethical issues and formal resolution. Both of those also contain an exception for confidentiality of the patient. And so in most circumstances, if the patient doesn't want you to report, you're not really going to do anything other than work with that patient clinically on whatever the impact of this incident has been on them. Document what you're doing and what you're not doing and why. As we'll probably say, document 20 more times in the next hour. But it really does matter that if a board ever has a cause to look at your record, that they understand that you engaged in a thoughtful analysis, you looked at what the laws and standards were, and your patient said no. And so you didn't report even though there was a clear violation, because you're respecting your patient's autonomy and you're following the letter of the law and or the ethics code. But don't forget about the clinical needs either. Someone who's experienced something like that may have issues trusting a therapy relationship, may need to work through things in a different way with you. So, look at your legal requirements, follow those if necessary, but also attend to the clinical needs of the person in front of you.
Yeah, great. Thanks, Julie. Mark, anything to add?
The only thing comes to mind is I think of these situations sometimes can bring about feelings or responses from the provider. And so if that occurs, then it may be a good idea to seek consultation on that so that you can ensure that that's not going to rise to the level of a conflict, which would impair your effectiveness of the services that you're providing to the client.
And that makes me think of something else. I mean, particularly if you know this other provider, if this is a colleague of yours or someone that you have a relationship with, that's going to create some pretty significant conflicts, I think. And so that's a great suggestion, Mark, to have the ability to process this in whatever way the clinician needs to as well.
Yeah, there's really both sides there. And as you said, Julie, getting back to what you said about, the clinical piece, it may even be important for the clinician to consult about clinical, like what new, as you say, there's different dynamics sometimes that this brings up when someone's been, experienced that before. So on both sides, as you'll probably hear us say 20 times in the rest of this conversation, consult, right? These are really important situations to consult. So yes, great, thank you both. And just Mark, to come back to our final piece before we start taking some of the live questions, as promised, returning to the issue of suicidal patients. And as I mentioned earlier, right, we are getting increased number of calls from clinicians who typically have very stable clients, but now are seeing an increase in suicidality and in fact calling with clients presenting with either moderate or very high risk for suicide. And so can you speak to some of the risk management strategies in that situation that you'd recommend for managing cases once that does happen?
Yeah, I'd be happy to. So I think first, it's important to keep in mind that someone with a moderate to high risk for suicide does not necessarily require inpatient treatment. sometimes that's where our mind automatically goes, which is understandable. It can be very stressful to be placed in that position. But even though it doesn't necessarily require inpatient treatment, it does require a heightened level of clinical expertise and care to ensure that the risk is managed appropriately. So I recommend a few of the following risk management strategies for managing these types of clients. So obtain continuing education. I think that's a good start in suicide risk assessment interventions. So again, this is going to speak to the importance of prior preparation for managing clients presenting with suicidality. Being forewarned is being forearmed. Become familiar with the suicide literature as it relates to assessment of risk and management techniques. As I mentioned before, a really nice comprehensive approach is a collaborative assessment and management of suicidality, or CAMS. And ensure that you're familiar with crisis intervention services where the client is located, as well as the state laws regarding dangerousness to the self and the procedures for initiating emergency interventions should that become necessary. Again, easier to do that ahead of time than in the moment. In cases where services are being provided remotely, though, through telehealth, it's important to consider how this might affect intervention and risk management strategies. So for instance, at the outset of every session being conducted remotely, confirming the client's location at the outset of each session, becoming familiar with the crisis intervention services where the client is located. So for instance, if I was providing telehealth to somebody in a different state and they went to crisis and I needed to contact emergency services, calling 911 in my state, they're not going to patch me through to the other state. So be mindful of that. Have a clear, informed consent that includes limits to confidentiality and your obligations as a provider. Remain mindful of the 3 domains of reducing liability overall. So foreseeability, which would speak to what I think a risk assessment approach, treatment planning, which is informed by the client's risk that we incorporate into their treatment plan, and then following up and follow through and in your treatment service delivery. Also, arrange for clinical consultation with 1 or more experienced colleagues for clinical and emotional support, and ensure that there's enhanced documentation. You could also consider that collaborative documentation along with the client. So this means that you're documenting changes over time, what was done, as well as what was not done and why. So overall, licensing boards, in a worst case scenario, they're going to be looking to see whether a provider was prudent. And this can be shown by a clinician documenting in detail the actions that were done, and that they were aware of their clinical and ethical responsibilities, that they considered relevant options, and they implemented a strategy designed to minimize the harm to the client.
Great. You covered a lot in a wonderful way. That was great. You got a lot in there, Mark. Julie, anything you want to add?
I don't have much to add other than to emphasize the documenting what you didn't do. And Mark did allude to that, document what you considered, because like he said at the beginning, a lot of times the first thought is hospitalization for stabilization, and that's not always the right course of action. But if a board is looking at your records for whatever reason, it would be good for them to know that you considered that and rejected it for a specific reason.
Yes, right. And then just to tag on to all of that, continued monitoring, right? And once you've done that initial assessment, maybe things improve, maybe they don't, but a continued monitoring and continued documentation of that monitoring. Again, even if it gets better, it's a good idea to still note in your chart that you're continuing to assess that moving forward. So great. All right. So we are going to turn to the Q&A, the live Q&As now. And the first question says, Blue Cross Blue Shield of North Carolina is requiring in-person sessions starting April 1st. Many clients are not comfortable with this. How should they handle that? Julie, why don't you start with that one?
I mean, that's a really tough one. When you have a requirement from an insurance company, there's not a lot of wiggle room. It would be potentially a breach of the provider's contract with Blue Cross Blue Shield to not follow that, and it would risk not getting reimbursement. And so, as you know, I think your option is to see the person in person, or reach out, have the clients perhaps reach out to Blue Cross. If enough people put up enough of a fuss, also known as advocacy, sometimes that can affect change. And we're not out of this public health crisis yet. And I could certainly understand people not feeling comfortable doing in-person services. Now, certainly you could try to accommodate them, everyone masking up, having all of those, air filters and ventilation and all of the different protocols we can try to engage in to reduce the risk. But if a patient says, I'm not coming in person, you certainly can't force them. You would just let them know the potential risk is that their services may not be reimbursed, and that they may want to reach out and advocate on their own behalf. And you could try to do that as well, to see if there might be some wiggle room or some ability to have exceptions, kind of like the Medicare rule.
Yeah, Mark, anything you want to add?
No, I think Julie did a nice job covering, and nothing else comes to mind.
Yeah, I think you're right, Julie, that maybe having them contact their insurance company and see if there's any exceptions. But yeah, if you're an in-network provider, you really are required to follow the insurance company's policies. If you're an out-of-network, you may not be required to follow their policies, but as you said, Julie, they may not reimburse the patient. So you'd want the patient to know that. So. Okay, another question on the Medicare piece. Is the distance of the office being more than 60 miles a good reason? I presume here they mean a good reason for maybe that hardship. And again, maybe, we're talking now about the in-person requirement for the 12-month period, not that initial one. And then there's the second question here, how will Medicare approve? And Julie, I might just let you jump in on that one too. And Mark, I promise to get to you in one second.
That's okay.
Yeah, I don't know what the parameters would be for these exceptions. The regulation itself says almost nothing, and it's the commentary that gives you a little bit of a clue. And I guess the key would be to think about that statement I made earlier, is the benefit of the in-person service outweighed by the hardship or risk of it, and document that in the record. Medicare may choose to audit that and take a look at that, and they may or may not approve. And I hate when we have to talk in theoreticals, because that's what we're stuck with right now, because we don't really know what's going to happen when this, suddenly the switch is turned on and here we go. But we're stuck with a lot of ambiguity right now. And all we have is that statement in the commentary that is talking about kind of that risk benefit analysis. And if you think you have a good faith argument that the burden and the hardship outweighs any benefit, then you just document that as carefully as you can and hope. Ultimately the consequences, you don't get reimbursed for that work.
Yeah, and just to be clear, because I know people jump in at different times to the webinar, that is only for that 12-month period. As of now,
Correct.
right, the way it stands, an in-person requirement will be required, like an in-person meeting will be required no matter what. There is no exception to that.
The commentary, I have the commentary in front of me right now, and it says, we note that there is no exception to the statutory requirement that the practitioner must furnish an in-person non-telehealth service within 6 months prior to the initiation. So at this point, the commentary is definitive on that.
Right. So if you don't have an in-person session in those 6 months, you're never really going to get to the problem of what happens in the next 12 months.
Correct.
Right.
So the exception is sort of irrelevant.
Yeah, in that case. Mark, anything to add?
I'm curious, I don't know if either one of you are familiar with this, but is there any use in perhaps reaching out to Medicare administrative contractors in your given state to gather any information on these exceptions? I don't know how beneficial that would be, or if you've heard about that being effective in order to vet some of these exceptions.
I think it's worth a try. It's always worth a try. But again, because this isn't happening yet, they're probably not going to have any guidance yet. Yeah. There's a bunch of test cases out there where we figure out how they're going to decide. But it's always good to try to get information straight out of the authority's mouth, so to speak. So there's certainly, and maybe, I'm hopelessly optimistic about advocacy working, but maybe if enough voices are out there, then that might impact things and affect some kind of change.
Yeah, I agree. I think it certainly can't hurt to do that. So it's a good idea. The other thing I'll say, sometimes depending on your state psychological association may be able to do some advocacy around this. I know some state psych associations have committees that focus on insurance issues. Not all of them, but some of them, and some of them have, they have a seat at the table within the states where this stuff is being discussed. So it's probably worth reaching out to them and finding out if they know of anything. So it's a great idea. Okay, Mark, so I'm going to send this one to you. And this is on the NSA, the No Surprises Act, which, you know, we've had many questions about. And the question here is, does the NSA apply to marital cases where no person has a diagnosis? So I think here they're getting at, like, if it's marital therapy and that's not technically a healthcare, you know, if insurance doesn't cover and there's no diagnosis, does the NSA apply?
Yeah, I haven't seen any exceptions that would suggest that this would fall outside the NSA requirements. And I think the diagnostic question, when you're looking at the form in order to document the diagnosis, which I think we get a lot of calls with new clients, and how do I complete this? Because there is no diagnosis, or I haven't formed that impression yet, or one doesn't apply. Our best advice is that to either put down a to be determined perspective or use the ICD-10 CM code. I believe it's R69 that suggests that there's no diagnosis applicable at this point. So yes, the NSA would still apply because this would be, you know, self-pay or fall outside insurance reimbursement. And so I would continue to follow the procedures, but I think when it comes to the diagnostic labels, you could use some of those alternatives to stay in compliance.
Julie, anything you want to add there?
I think it's a really interesting question, and I like the angle that we're trying to get to here. But from a risk management standpoint, looking for creative loopholes is not always the safest thing to do. And so, I mean, I understand the argument, if this is not a reimbursable healthcare service, then maybe it does fall out of the scope of NSA, but I haven't seen anything that's definitive on that point. And we are taking a fairly conservative stance on our interpretation of the NSA, even though it's very burdensome and very frustrating. We don't want our clinicians to get in trouble. And so I would say that we may be wrong, but to be safe, I would consider that to be something that would fall under the purview of the NSA and would require a good faith estimate.
Mm-hmm.
Yeah, and I like what you say, Julie, about the conservative response at this point, right? Because it's still pretty new and a lot of stuff hasn't yet been worked out. You know, I think this falls in a particularly gray area because we certainly would say that forensics, for instance, if you're doing a forensic custody evaluation, that's not covered under the NSA because it's not healthcare, right? So, but this is a little bit more gray, you know, couples therapy is a little, you know, it's not as clear cut as forensics in terms of being specifically not healthcare, right? Like a custody eval or something. So yeah, when you're in a gray area, and at least until we know more about how this is going to shake out, better to err on the side of caution. So great, thank you. A quick question, let's see, just to clarify something. So it sounds like this person does mostly evaluations. If we're only doing a psych eval, and we see a person one time, I assume this is meaning for Medicare, must they see them face to face?
Well, I would argue yes, if it's initiated after the end of the public health emergency. Once this requirement goes into effect, right now, no. Now until April 16th, there is no such requirement. And so it's going to depend on the timing of things. But if it's something that you expect to get reimbursement from Medicare for, once the public health emergency ends, you need to follow that in-person requirement. Because it is supposed to be, technically, you're supposed to see them in person within 6 months of initiating the telehealth service. So seeing them by telehealth to do the assessment after the end of the PHE wouldn't actually meet that requirement. But if you squeezed it in while we're still in the public health emergency, then there is no current such requirement, so you could do it. Excuse me.
So it'll be important, of course, as always, to stay up to date on the changes that are coming. So yeah. Another question on Medicare, is Medicare in-person requirement applicable if providing services as an opted out provider when the client is not allowed to file claims? And Julie, do you want to, just because you're on the Medicare hot seat today, I'll give that to you. And
it's my favorite place to be. You know, that's a really good question. I mean, the regulation is about getting reimbursement from Medicare. And so if you're not expecting to get reimbursement from Medicare, then I don't see why you would need to follow the regulation. The way it's worded, it says in order to get reimbursed, you must meet these criteria. If you've opted out, you have a private contract and it's self-pay, my interpretation would be no, you don't need to worry about that because you have no expectation of reimbursement from Medicare, that is.
Yeah,
I think that makes sense.
Yeah, you agree, Mark. Yeah, because also the patient's not going to be filing a claim, so there's going to be no claim either from the clinician or the therapist. So, all right. Okay, so I'll ask this one last time just for a quick repetition, and then we're going to move on to some other topics. But I have an ALS patient on Medicare. He cannot walk or drive and can only talk via computer. At this point, it is essentially impossible for him to travel to the office. Can I document that? Would that be sufficient? And Julie, I'll let you comment one more time.
My best guess would be yes. That seems like a pretty compelling hardship where the benefit of the in-person service would be outweighed by the hardship to the patient. So I think, again, hypothetically guessing what would happen, but that seems to me to be the kind of thing that would meet the letter of that exception. That's a true hardship, and I would have to just hopefully guess that yes, that's going to meet. If that doesn't meet it, I'm not sure what would, quite frankly.
Mm-hmm. So again, that would be for those 12
month sessions. Yeah, somehow you have to get that initial session in, though. That would be the trick. So the clinician may need to travel to the patient for a session, or there may need to be some sort of arrangement made. I don't know what that would look like, but again, there is no exception for that initial within that 6-month period. So something would have to be done, or I don't know how that person would get services. That's incredibly unfortunate.
Mm-hmm.
Yeah, and that's a case where it's so extreme. I would wonder about contacting Medicare in particular and find, like, look, the patient literally is physically unable to get here. It's not that we don't want to do it, or, so there might be some sort of single case exception that could be made that would be worth maybe arguing for there. So, okay, so another Medicare question, but Mark, I'll shoot this one to you. Can Medicare patients opt out of using Medicare benefit to see a behavioral health provider?
So in terms of the opting out process, yes, that's available. You either enrolled and you're a participating or non-participating provider under the enrollment, or you opt out by going through finding your Medicare administrative contractor. There's a list which I can identify which states are participating, and then you can search to see which organization is overseeing, and you can find then an affidavit for opting out. Previously, I think it was 2015, for some reason that year's in my mind, where you had to renew it every 2 years. That no longer is the requirement. It'll automatically renew every 2 years at this point. But that would still apply for those if they're reimbursable to opt out through that procedure.
Yes, and to clarify, that's the clinician opting out, not the patient.
Yes, correct.
The patient can't opt out. It's only the clinician.
Yes, yeah.
Great, thank you. Julie, anything you want to add there?
No, I was just going to say what you said, that the patient can opt out in the sense of choosing to see a provider who has opted out and entering into a private contract with them for that self.
Yes, yeah. But if the clinician has not opted out, then a patient can't say, oh, I don't mind, I'm happy to pay you. That would be problematic.
Correct.
Right.
Yeah, great. And so there's a couple of these questions, but the basic gist is, if Medicare is going to this, one in-person visit, either 6 months or a year, do we expect or foresee that other insurance companies will do that too? Now, I know we don't have a crystal ball, but Julie, can you speak to that a little bit?
Yeah, it's an interesting question, and it's a good question, because we do tend to always say, whatever direction Medicare goes, that's where private insurance is going. I'm not sure I feel the same way about this, because this in-person requirement existed before. It has just been suspended during the public health emergency. And I don't know how many private insurers actually required an in-person session. I'm sure some did and some didn't. I'm not sure this is going to be a trend. I actually think this is an exception to the direction that everyone else is going in. Every other insurer, every other indication I'm seeing is that we're trying to expand the availability of telehealth, that we've recognized over the past couple of years that, wow, it is actually effective and convenient and people can benefit from it. We've done this like forced experiment of what's it like to do teletherapy. I would be really surprised if they started to try to clamp down on that. We have such a crisis of access to care right now. And I know, insurance companies don't necessarily try to solve that, but it would seem to me to be going in a very different direction. And I'm actually frankly surprised that Medicare is keeping this hard stance on this. So again, crystal ball, I don't know, but my guess is not necessarily. I'm not sure that that's the direction everyone's going in. I frankly think things are going in the opposite direction to make it easier for people to be seen remotely, not harder.
Mm-hmm.
Yeah, I wholeheartedly agree with Julie's take on that.
Yeah. And I'll just come back and say, if it does start going in the other direction, that is where I think advocacy, strong advocacy is, that's where we as clinicians have to urge APA, our state psych associations, whomever, to really get out and advocate against that. Because that would put significant hardship on a lot of people. All right, so another question. I am licensed in multiple states doing telehealth in all the states in which I'm licensed. A patient said her insurer will not reimburse her, and keep in mind this is an out-of-network provider. So the patient's insurer will not reimburse her unless the provider's invoice for her has the provider's address in her state. So this is a cross-jurisdiction issue, and the provider's address is not in the client's state. And the insurance company is saying they will only reimburse if the provider's address is also in the same state where the client is. This provider does not have a physical office in the patient's state. Can the provider ask a colleague in the client's state to use their address on their letterhead, or would that be considered fraud? And again, this is all telehealth. Mark, do you want to jump in there?
Is there any indication of the physical location, if there's any further restrictions or requirements noted by the insurance company that means solely, for instance, a virtual office where you have one in kind or a registered agent in a particular state versus having an actual physical location of an office? I think that may depend.
It looks like it said in the question, it says that they will, so that a patient said her insurer won't reimburse her unless my invoice for her has my address in her state, even though my NPI number is tied to a different state and I don't have a physical office there. So it looks like it's pretty concrete.
Yeah, I would be concerned with using a colleague's address just because I fear that that could be construed as trying to be, or at least lack transparency or try to mislead the insurance company. I think, like we've spoken about before, insurance companies often they write their own rules, and there may be some opportunity to allow an exception, though some of the language used in this question suggests to me that they're pretty staunch in this requirement, so that may not be an option. Now, there are other options, if it has to be your location, assuming that it's your physical location where your office, meaning that they want you to be providing services within the state for some reason, that would really probably, there really wouldn't be many options. Although if they express some flexibility, like a registered agent in that state or some sort of a virtual office, that may suffice. But I'd want to clarify that on the front end. I wouldn't assume that a colleague's address would be sufficient, and I would worry that that might have negative repercussions if the insurance company was to find out.
Yeah, I agree, Mark. I think that anytime you're doing billing and that kind of thing, you really do want it to be very transparent. Anytime you try to hide something, it can look problematic, like fraud. Julie, anything you want to add there before we?
No, I agree. I think it's a question that needs more questions, right? They need to get some clarity from the insurance company. Is this just a box you need to check off that there is an address, or does this actually need to be a physical location of my clinician's office? And then that might make a big difference. If they just need to have some sort of address, then a virtual office might be, or a colleague's office might be a perfectly fine solution, but they need to get clarity before they take that step. Otherwise, yeah, the F word, fraud, we don't like that.
Right.
The other F word.
Because, yeah, you want to make sure it doesn't look like you're trying to say that you, the clinician, are in that other state. That's the problem.
Yeah.
And so we want to stay away from that. Okay, so Mark, there's several questions here about the assessment tools that you recommended about suicide. So if you can maybe just repeat what you recommended in terms of some of the tools, and then also can you address whether or not those tools apply to children and adolescents?
Yeah, so the tools that I mentioned, first one was the Columbia Suicide Severity Risk Scale, or the acronym is C-SSRS. The other is ask suicide screening questions. The other is Beck hopelessness scale. And the last that I had mentioned was the suicide status form, which I noted accompanies the collaborative assessment management of suicidality, the CAMS approach. Now, I am aware that these are used with adults primarily, although when you look at the items on some of these scales, you can see that for, say, the Columbia, for instance, it's used as a structured assessment tool to look at suicidal thoughts, the frequency, the intensity, if there are any suicidal behaviors, if there's an intent, if there's a plan, if there's a method. So you can see that in a way it could cross over from adults and be just as useful with adolescents, although I can't speak off at this point to the level, the extent to which that's been studied. That tool in particular has been studied with adolescents. I highlight that one because I'm most familiar with that. I've incorporated it into some of my own suicide risk assessments with adults. But I would imagine just knowing about the general factors that are looked at, that it would apply or at least be helpful to structure your assessment of suicidality in adolescents as well.
Julie, any additions?
I don't have any specific information about child or adolescent specific assessment tools. I am sure that there are some out there that have been validated on that population. I just don't have the information, and I don't want to Google it while we're all on here.
Yes, and I will say, I mean, as we all know, right, you do want to be sure. I mean, I think you are right, Mark, and I would agree that that might be at least get you thinking in the right direction if you're looking at that. But if the Columbia has not been studied or researched with adolescents, you know, you do want to know the literature on the group, the population that you're serving. And there can be some key differences between adolescents and adults in terms of the assessment and treatment. So, you know, if you're seeing an adolescent population, that's one of those places, like Mark said earlier, really good idea to get some CEs or something, you know, and some of that specific to adolescents. Okay, another question. This is more general, and Julie, I'll shoot this over to you. What are the elements of a good regular clinical documentation? What makes a session note good or strong? It's a $24,000 question.
Such a good question, and it's always shocking to me how little guidance there is. There's not a lot of specificity on what's in a good note. You know, the APA has record-keeping guidelines, but you know, it's all very fuzzy. So when I think about documentation, first off, if you are under contract with insurance companies or Medicare, sometimes there are requirements of what needs to be in there. So you need to be aware of any contractual requirements. Sometimes there literally needs to be a start time and a stop time for each session. That's not something we might normally use, but you do need to be aware of any specific requirements based on contracts. Other than that, one of the ways I try to conceptualize this is, if I were to fall off the face of the earth tomorrow, could another clinician pick up the record and know what was going on? That doesn't mean that I have written the entire narrative of this person's life story, but there's enough in there to prompt another clinician to ask questions. You know, if there's trauma, then I can indicate there's trauma. I don't necessarily need to indicate a lot of details about that. But I do think that for me, that's a way I try to think about it. Could someone else know enough about what was going on in the care to pick up where I left off? Now, certainly we have SOAP notes and DAP notes. We have different ways to structure notes. I think those are good tools to have. You know, you want to have some sort of objective assessment each session. You want to have a little bit of a narrative about what happened in the session, what are the plans and goals for the next session. So something along those lines, some kind of structure is nice. You also want to think about other potential audiences for your record, like a licensing board. So documentation as a risk management tool, again, because in a higher risk situation or in any kind of situation where things are slightly unusual, you may be deviating from the standard of care, you need to document what you're doing and why, and you need to be able to outline and explain the actions that you've taken. And so think about the different audiences, have enough there for another clinician to know what's going on, have enough there for a licensing board to know what's going on, and be aware that your patients have a right to access the record. And so write things in objective terms. Don't write anything you wouldn't want your client to see, that you wouldn't be able to explain to them or justify in some way, because they do they have a right to access it. A lot of people kind of think, no, it's my record, but that's actually not. You're sort of keeping it on behalf of your patient. And so make sure that there's nothing inflammatory or problematic in there. But it's a really good question. Some states do have guidelines on what needs to be in the record. So again, go back to your state board website and see if there's any kind of record keeping rule. Look at the APA record keeping guidelines, but they don't really give you a lot about what needs to be in each progress note. And I'll just close with the fact that there is a massive continuum. Some people have very, very lean notes. Some people have very, very detailed notes. I think the truth is somewhere in the middle in most situations. You don't want it to be so lean that no one knows what the heck was going on, right? You need to say more than they showed up and they're coming back next week. But you don't need to write a dissertation every week either. Lisa, you are muted.
Wow, okay. Mark, any addition to that? Thank you, Julie.
A couple thoughts. One, I think about this dose response when we have complex cases or high risk cases. I think that the burden upon us to demonstrate and detail our approaches, what we did and why, as well as what we didn't do and why, that's something to consider, because exactly what Julie said, if worst case scenario, if there are other eyes on this, especially a board, psychology board, we want to be able to demonstrate that we were prudent practitioner. The other thought is that for those of you who may not be familiar or aware of this, but on the Trust website, if you go to the Resource Center dropdown, find the document library, there's an electronic health record templates that are available for each state. It gives you some really nice, useful information about across different states about the type of information to put into a record at the least, and the types of requirements that might be associated with your given state.
Great. Yes, you hit the two things I was going to add, so we're right on the same track.
All right.
I like it that way. Okay, so another question. With regard to neuropsychological assessment, if a patient is diagnosed as having neurocognitive disorder with a profile concerning for their continued driving, but the patient refuses to allow their assessor to meet with family or other collaterals, including their medical team, is there any further follow-up that the assessor has to do other than just documenting? Julie, you want to jump in on that?
You know, there's not a whole lot that you can do beyond documenting the steps that you've taken to try to ensure safety and that people are aware of what's going on. But I'm not, you know, this is sort of a risk situation, but it's not an imminent risk. It's not the kind of thing that you would be able to breach confidentiality and share information about the assessments. And so I think you just need to make a lot of reasonable attempts to ensure safety and to ensure that people know about this restriction, but there's not much you can do to stop this beyond that, or to inform people beyond that without the authorization of the actual evaluee.
Mm-hmm. Mark, any additions?
I agree. I think this is documentation. I wonder what number that is, but this is one of those cases where you want to clearly spell out the limitations that you are experiencing and the concerns, and make sure that that's well represented in your record.
Mm-hmm. And the only thing I'll add there is you might want to check to see if there is any kind of state law that would mandate something. Some states do have quirky laws, so you really do want to know what your state requires, because that would be the only, I think, the only exception that to what you're saying that I can think of. So